Hello, everybody. Welcome to today's EACVI webinar on contrast-enhanced stress echocardiography to assess the need for coronary intervention. I'm your host for this webinar. My name is Professor Roxy Senior from Royal Brompton Hospital and Imperial College London. And I have with me here Dr. Nicola Gaibazzi from Parma, Italy, and Dr. Costa Zacharias from London, UK, a consultant interventionalist with an interest in stress echo. The aim of this webinar is to give you an informed understanding of how is contrast echocardiography performed, both for assessing wall motion and perfusion, how does it detect coronary artery disease, and how it can risk stratify. And then finally, this webinar will highlight the role of contrast stress echo in guiding which patient should undergo coronary intervention in our daily clinical practice. This will be illustrated with case examples. At the end of the webinar, you will have knowledge of the basics of contrast echocardiography, used during stress echo, protocols used, how regional wall motion abnormalities and perfusions are assessed, the incremental value of perfusion over wall motion, both in the detection of coronary artery disease and prediction of outcome, and finally, how contrast echo helps guide patient management in terms of coronary intervention. The session will be highly interactive. We strongly advise and encourage the viewers to submit questions online throughout the webinar. We will endeavor to answer as many questions as possible within the constraint of time. For optimum participation, we will also encourage you to join in the online MCQ session where you will need to answer questions pertaining to the webinar that you attend today. Finally, I would like to add that this webinar is made possible through an unrestricted educational grant provided by Bracco, Milan, Italy. So now I have the pleasure in handing over the talk to Dr. Gaibazzi, who will start the session.
Thank you, Roxy. It's a pleasure being here. Thank you to the host. These are my disclosures, and we'll try to have a look at the new guidelines, the new recommendations that have been issued very recently by the European Association of Cardiovascular Imaging, and Dr. Roxy was the chair. So in stress echo nowadays, in stress echo labs, today contrast echo is highly recommended for patients undergoing stress echo using vasodilators, using dobutamine, and also for high-risk patients undergoing exercise. It is recommended to consider the use of contrast for perfusion and wall motion assessment using very low MI, mechanical index imaging. This is now a class 1 and level A recommendation, which really changed the game a bit. This is also a very safe modality. You can see that the occurrence of the side adverse events is low and is comparable to antibiotics and other drugs like analgesics and and contrast media, gadolinium-based contrast media for CMR. So this is a very safe and highly recommended method, in particular for stress echo.
So, Nicola, very quickly, so regarding these guidelines, do you think this class 1A recommendation of myocardial perfusion in stress echo is a big step in contrast echocardiography?
Sure it is, Roxy.
Yeah.
Sure it is. In fact, the use of contrast can perfectionate stress echo examination, and we'll try to discover how in a few seconds.
Yes.
And microbubbles just require a little bit of knowledge of how to use ultrasound with contrast echo. We call it microbubbles because it's based on microbubbles. They have the diameter of a red blood cell, more or less, few microns, and they behave like a red blood cell. And they are fully intravascular. So as all the kids know, you need to treat the bubbles, which are very fragile, with care. And so it's the same with the ultrasound. You need to lower the mechanical index, the power that impacts against the microbubbles. So you need to use low mechanical index. In this case, very low mechanical index is what is really recommended recently by the recommendation of the EACVI and also from the American Society of Echo next upcoming guidelines. So when you use contrast, first consider that you need to lower down the mechanical index down to 0.1, 0.2, so that you can avoid that microbubbles are distracted by your power. These are some examples how it looks like. You see in the upper row standard 2D echo, which employs approximately 1.0 of mechanical index, so more power than is used during contrast echo. Contrast echo, typically shown in the mid row, is the so-called opacification setting. So it's just a low or intermediate mechanical index, 0.2, 0.3. And then the perfusion setting, so-called perfusion setting, is a very low mechanical index setting, which is now considered and recommended, with some exceptions, which may be the structural diseases when you want to be a little more clear on the definition of the morphological aspect. For example, when you have non-compaction, which is, in which cases you're recommended to use slightly higher mechanical index, 0.2, 0.3, with the opacification setting, which employs harmonics also. So you can see some examples here.
So, Nicola, it's a very important point that you raised, and it's also recommended in EACVI, as said, that if you look at the middle images where in the LVO setting, though you can see the contrast very well, but you can also see some bubble destruction and also some structures in between which may obscure the endocardium. Is that right? And with the low mechanical index setting, you actually abolish that and you just see the endocardium and the epicardium.
Absolutely.
And that's a major advantage of doing low MR imaging, isn't it?
I definitely agree. So when you use contrast, you can use it triggered to the type of image you want to better define. So if perfusion and wall motion is your key aspect you want to assess, you definitely need a very low MI imaging. There are other curiosities. For example, you can assess the LAD using color Dopplers. You can see in this image very well using contrast. Contrast is defined in the new American Society of Echo guidelines as an ultrasound enhancing product. So this is something that helps if you're going to measure, for example, to use Doppler coronary flow reserve, as it's in some countries is done. Anyway, the very low mechanical index setting is the one that is recommended nowadays. This is based, perfusion assessment is based on an easy concept, the concept that you can see on the right in a first in a 4-chamber and in a 2-chamber image. You can see this flash replenishment concept. This is a destruction of microbubbles obtained through putting your machine at the standard ultrasound mechanical index. So standard power, the one that you use without contrast for few frames. See this flash, we call it flashed. And then we can assess the replenishment, the so-called replenishment. So how the myocardium refills. This is normal if within 2 seconds there's a full replenishment at stress phase. So if there is a defect, similarly to other methods and modalities for functional imaging, this will probably be subtended by a coronary stenosis. There's an amount of data, there's an incredible amount of data starting from first papers by Dr. Senior, and then in 2000 and on, you can find ideally published papers comparing the data coming from quantitative or visually assessed perfusion using contrast echo with, for example, invasive Doppler flow wire, a comparison with quantitative angiography, a comparison with PET also, comparison, a very recent comparison with SPECT, also using the quantitative type of myocardial perfusion assessment, which is much more difficult to be used in clinical practice, but it really works. It's a proof of concept that the method works. We nowadays almost in every center use visual assessment of perfusion imaging, which is easier and faster. But the data are there, the data is there, and you can easily realize that this is not an orphan method. This is a method that's been used in so many studies, and this is from the guideline, from the recommendation of the EACVI EACVI, and you will see that vasodilator diagnostic studies put at least 3,000 or 4,000 patients, while for dobutamine and exercise you have more than 5,000 patients who were studied, and the sensitivity and specificity is almost the same, 80% for vasodilator and dobutamine exercise, and 80% specificity using contrast, so using perfusion on top of wall motion. And this is an example of how myocardial perfusion assessment relates to invasive techniques and to revascularization, for example, and how it may help not only as a gatekeeper to coronary angiogram, but also to assess possible problems or other facts regarding the period after revascularization. This is a four-chamber view when you can assess normal wall motion at rest in a patient who was revascularized using PCI of the LAD, and you can see that at stress phase it's quite easy to understand that the septal branch was occluded by the procedure itself. So you can see both the wall motion defect abnormality and the perfusion defect there in the mid septum in the subendocardial part. So the definition is also very, very high compared with other methods such as nuclear, for example. And you can maybe see this better in this triggered image, which is one of the types of imaging that you can perform when you use contrast. You can maybe sometimes better assess perfusion using this type of method.
So Nicola, this is a brilliant example of how just a septal branch, occlusion, it's a small branch, you can actually detect the perfusion defect, and perfusion defect was seen very, very clearly, and the wall motion was a bit subtle. But the perfusion defect really brought it out, the wall motion abnormality very well.
You're right. Perfusion helps detect even subtle wall motion abnormalities. This is something that we see every day in our lab. When you perform echo without contrast, you may have some shaded areas or something that's not very well defined, while when you have contrast and perfusion data are in your image, you will more clearly assess the wall motion. This is just the only example, case one, we'll call it. Rest imaging with contrast real-time, very low mechanical index imaging integrates both wall motion and perfusion information, as we said. This is a 50-year-old gentleman who was referred for standard echo. This is rest echocardiogram. This is not stress echo, for example. So contrast may be very helpful also in cases of rest echocardiograms. Because of an episode of a typical recent 10-minute chest pain episode, and with borderline T abnormalities. Almost every cardiology knows that ECG is not easy to interpret always, and it may depend on the way you look at a part of the ECG. So it's not that you have positive, normal, or abnormal electrocardiogram. Most of the times, or sometimes, you have these borderline ECGs, and contrast echo is quite helpful in those cases also. So you see on the top line, you see the non-contrasted echocardiogram, standard echocardiogram, where you can see the four-chamber, and you here can see the perfusion setting, so the very low MI setting, imaging setting, 0.1 approximately, real time, with some contrast in your heart. You can see the left ventricle here. The image is quite different because we changed position probably, but this is the same left ventricle, and you can see that probably wall motion is okay. When you pass to the three-chamber view, you will probably see that this is apparently, but I won't comment anymore because this is a question, and we'll have multiple choice answers. So let's have a look at the three-chamber, non-contrasted and contrasted image. That doesn't move perfectly, but you may get a handle on what it means. This is a two-chamber. Let's stop this, stop this. Excuse me, we're just trying to start only exactly. Now it's a two-chamber. You can already see that the anterior segments are not very well visualized without contrast, while they get visualized with contrast. I won't comment because this is the subject of our question. How would you interpret wall motion in this rest echo, either in uncontrasted, the normal standard echo, and the echo with contrast? So normal standard echo, but abnormal contrast echo, suggesting disease in the right coronary artery. The same, so abnormal standard, not the same, abnormal standard echo and abnormal contrast echo suggesting disease in the circumflex coronary artery. Normal standard echo, but abnormal contrast echo, suggesting disease in the left anterior descending artery this time. Normal standard echo and normal contrast echo, and abnormal standard echo and abnormal contrast echo, suggesting two-vessel disease. Let's get back to the images.
So the voting starts now. You have 30 seconds to answer the questions.
So again, four chamber is shown here, without contrast and with contrast. Have a deep look at it. We are asking wall motion. We're not asking perfusion here, at least not directly. Then we have a three-chamber, without and with contrast. I remind you, this is a rest echocardiogram where the patient with suspected chest pain of cardiac origin, of coronary origin, and this is a two-chamber. So do you think this suggests that this is normal or this is abnormal due to one of the three or more than one of the three coronaries?
So Nicola, while they do their selections, you showed a very important slide of this low, or rather, safety of contrast.
Yeah.
And you showed a slide where the safety is such that it is almost like, it has no issues at all. So what do you think of that? I mean, in other words, there's out there in the cardiology community where they still talk about safety being a problem with contrast. What is your experience in your lab?
Well, my experience is maybe too good to be true. So I never had a single severe side effect from contrast, but from stress echo. I have a couple of colleagues who do not use contrast, and they had much more serious adverse events than me. I think that there is something in the use of contrast that lets you stop the test well before what you would be doing without using contrast, because you're looking for wall motion abnormalities, while with perfusion you can spot very easily and earlier the abnormalities, and that's safer to at least in my experience. Yeah.
Okay, so I think the voting is done, and we've got the answer here. So the majority thinks that it's normal standard echo but abnormal contrast echo, suggesting disease in the left anterior descending artery. So 52% actually voted for that.
Great.
And I think that's a great answer, because one can see that contrast really contributed to making a decision in this case of subtle wall motion abnormality, actually.
Sure.
So do you want to actually
yes, that was a subtle wall motion abnormalities, but that was subtended by some mild perfusion defect. These weren't sequences intended to perfusion assessment, but anyway, you always have some perfusion data. And while you can see rather well with contrast that distal anterior segment, but I would also add, let me try to use this. I would also add the three-chamber here. The distal septum, I'm quite sure you agree with me, is a mild wall motion abnormality, but it's clearly you're clearly helped by, let me go back a bit, by the perfusion defect. Here I put just the frames. You can see that there's a defect here, there's a defect here in the subendocardium, and there's a defect here. So the perfusion defect, which is also wider than the wall motion typically, helps you detect the wall motion abnormality.
And if you just go back to your where you show the unenhanced images again, I think there's one more thing. So if you look at the two-chamber view, for example, right, and you can see in the two-chamber view, you know, the anterior wall seems to be coming in so well in the non-contrast echo. But with the contrast echo, you actually see how the anterior wall is not actually thickening that well.
Yes.
And that is probably because what you see in the non-contrast echo is some trabeculation on top of the endocardium, and you're actually not seeing the endocardium.
I perfectly agree.
Yeah.
I think contrast helps you cut the heart, the left ventricle, in more proper ways,
yes.
and the image enhancement helps you to be more diagnostic by moving your ultrasound probe and try to find the best images. While you give it for granted, you're seeing the anterior wall here. In fact, that wasn't your.
That wasn't the anterior wall. Yes.
Perfectly right. And this is the angiogram of this gentleman. And you cannot say that this is not relevant to your clinical practice, because if you have such an angiogram, the information that the echocardiogram wasn't normal is very relevant to you. Let's go on to another example. This is not very dissimilar from the previous one, as Dr. Signo said, Professor Signo said, that here you have a two-chamber, and we'll discover this rapidly. Patient with recent chest pain, standard echo, shows only known infrabasal akinesia, which is known because he had a prior inferior MI. But when you activate the low intermediate, in this case the opacification preset is already diagnostic, you can see that the apex actually is not normal at all, and the anterior apical segment and the inferior actually also apical segment are not normal. When you do not contract normally, when you add the information from perfusion that very low imaging gives you, you can easily realize that the apex is not perfused. There are no bubbles there, even without using the flash replenishment sequence on the left, I think, while on the right you're using that. And you can see that the perfusion defect is probably the thing that highlights very well also in the other setting, the wall motion abnormality. In this case also, you can see that there was a problem in the medial AD. Quite severe problem. So again, contrast in rest imaging may be very helpful, although we mostly talk about it for stress echo. So let's go a little bit faster. This is the type of image you see in other cases, not so rare cases. When you have normal wall motion at stress, this is a 4-chamber, and you have perfusion defects in the flash replenishment sequences. You can see the perfusion defects starting here. See that? Okay, now there's the flash, then the myocardium gets all blackened, and there's a late refill or a late replenishment here, starting from here down to the lateral wall. So this is something that lets you think that there's a problem in this guy, even if the wall motion was normal, and in fact you had an almost left main equivalent disease. So again, useful in rest and in stress echo. Data for prognosis, we've seen the ones for diagnosis, but data for prognosis is there. You have so many studies, and Professor Signo also performed some. And interestingly, you have an effect, a stratification capability that is almost constant across several different subgroups. So even for patients at very high risk, such as previous CAD, previous MI patients, diabetes patients, you have that a normal test for perfusion and wall motion, both of them, gives you a very, very low, I think unprecedented by other methods, probability of heart events. Well less than 1%, also in higher risk patients. So we tried to look at our data to try to understand whether how to use the perfusion and the wall motion data regarding future revascularization. This is no prospective study. This is retrospective, and so it should be. It just suggests something. In our data, there is a suggestion that the more ischemia you have, so the more wall motion abnormalities you're going to see, the more revascularization is indicated. In fact, when you have no wall motion abnormalities, but revascularization, the events are higher in the follow-up, heart events, MI, and death, cardiac death. While when you have significant wall motion abnormalities, you have that revascularization is favorable. So these are not prospective data, but the suspect, and I'd like to talk with Dr. Senior with that, about that, the suspicion that perfusion should not automatically indicate revascularization is there. This is the last case, a couple of slides. This is a guy, a friend of mine actually, who had an episode of AFib during ECG treadmill test with some borderline ECG ST abnormalities, not very clearly interpretable. I sent him directly to CTA because I hoped that it was completely normal and I could send him home. My colleague, radiologist, told me that there was 60% disease stenosis on the LAD. He quantified that at 60%. So I didn't know what to do with this guy, who had also plenty of calcium, as you can see here, down the LAD, and not only on the LAD. So my best guess was, let's perform a stress echo. And this is to show that stress echo using contrast is not always useful only to see more problems, but sometimes it's actually something that relaxes you about the future of the patient. This is a rest image without contrast. It's not running smoothly, but you can probably see that it's normal. 4-chamber, 2-chamber, 3-chamber. Then you can see with contrast, very low imaging, very low MI imaging. This doesn't move perfectly also, but you can see that the 2-chamber is normal, the 4-chamber is normal, the 3-chamber is normal. And when you have a look at the wall motion at stress after dipyridamole 0.84 in 6 minutes, you will see that probably the wall motion is absolutely normal. But this doesn't relax me to that point that I send him home. I also measure routinely the CFR. Here you can see not a very good image for Doppler, because Doppler, pulse wave Doppler is not perfect when you use contrast, while contrast gives you a beautiful color Doppler. You can spot coronaries for long spaces. While when you measure the Doppler flow with the pulse wave Doppler, this is a little bit tricky, but you can always measure the peak diastolic velocity, as in this case, and it was more than 2, the CFR. So the wall motion was normal. CFR with Doppler was normal. And I can tell you the CFR was normal also at the myocardial tissue level. And perfusion, in fact, is perfectly normal. You will see here some artifacts, which is typical of perfusion, which is probably one of the reasons it's not being used by more people. There are some artifacts you need to build a learning curve, but this is a perfectly normal, so we call this the triple normal. Triple normal for wall motion, normal perfusion, normal Doppler coronary flow reserve on the LAD. This is extremely reassuring regarding the future. No very low, very low events for a patient like that. So it helps you relax also for negative tests. Thank you.
Thank you very much, Nicola, for this excellent presentation. So just before we move on to the next speaker, one quick question for you. So the fact that the wall motion and the perfusion were completely normal, despite the patient having a 60% narrowing of the coronary artery, is very reassuring in terms of ischemia. And certainly such patients, of course, you will not revascularize. Is that what you would say?
Yes. I think you can add something regarding, for example, the ischemia trial and other recent studies that there is no need to revascularize patients if you can control the symptoms and you realize after a functional and also an anatomical test may be helpful sometimes. It's not that sometimes it's put like functional testing against CT or stuff like that. I think that you should consider what the data is now for revascularization.
Yes, so the fact that the wall motion and perfusion is normal already puts the patient in a very low risk group.
Very low.
And therefore you really don't need to go down a high risk procedure like revascularization. Okay, so now we move on to Dr. Kostas, who, as I've said, is a consultant interventionalist with an interest in stress echo. And so, Kostas.
Thank you to Professor Senior and to EACVI for inviting me to participate in this webinar. So I'm going to try to give you the interventional perspective. May not be as clever as the stress echo doctor perspective, but still useful. So I work in 3 places. In my district general hospital, which serves a population of about 500,000, which is one of the most diverse, both in terms of ethnic substrate and the socioeconomic classes in London. And our tertiary center, which is King's College London, where we perform high-risk PCI and primary PCI and cardiac surgery. But I spent quite a bit of time working with Professor Sin in Northwick Park Hospital in the stress echo field in my previous career. And therefore, I'm a bit of a hybrid and was invited to give this talk. I have no conflicts of interest, but I would very much like to thank both Prof. Senior and Dr. Bino Issa, one of my my stress echo fellow colleagues, who gave us some slides for this presentation. So I would like to start with an MCQ that it's quite easy, just to set the setting. So in your stress echo lab, do you have access to echo contrast? Do you use echo contrast only for some cases? Do you use echo contrast for most of the cases to look at wall motion? Or do you use echo contrast to perform perfusion in all of your cases? So if you can vote on that now, I will tell you that it's not as embarrassing as it sounds, because there are still some centers in the UK where echo contrast is treated like a controlled drug. It's locked somewhere under lock and key. You have to find the matron to give you access to it, only in certain cases. And very few places use it routinely to perform perfusion in all of the cases, probably places with experts like Professor Senior or Dr. Gaibadze. So how is it looking?
Yeah, so the voting continues. I think they've got 30 seconds to 1 minute to complete it.
So I will give you my personal experience, because obviously there's no correct answer in this. Nowadays I use echo contrast in all of the cases I will do exercise stress echo on. In most of the cases I will do dobutamine stress echo on without actually thinking about it. And if we had the perfusion protocol, we'd probably do perfusion in all of our cases, but we don't in our district general hospital, we do in our tertiary center. So it's somewhere between 3 and 4 in my case.
Right, right. And so, but what the interesting thing is, you had your interest in interventional cardiology, but you still wanted to come to learn stress echo. So why is that?
Yeah, because I think it's important as an interventionist to be dealing with the whole of the ischemia substrate, not just the end bit, but from the diagnosis of the ischemic patient to the end. I think you're in a better position to assess the need for intervention if you have some understanding of a functional modality. That was the main reason in my case.
Okay.
Okay,
I think we've got some answers here. So 37% said, I do not have access to echo contrast media.
So about a third of it.
Yes.
So maybe at the end of this talk you can understand that if you get access to stress echo contrast media, it would be actually cost effective, if anything else.
Absolutely. So in 51% of the voting, it is echo contrast used only for some cases.
For some
cases.
I
think this webinar is very relevant.
Very relevant.
Okay.
So let's move to the second MCQ. Again, no correct answer, just to see what the clinical practice is across people who are watching. Do you use stress echo as a first-line test to look for or rule out ischemia in new patients? Do you use it to determine ischemia burden in known coronary artery disease patients? Do we use it to look for viability? Or do we use it for all of this? So again,
so let the voting start. And
so again, as I said, there's no correct answer, it's just setting the theme. I would say that nowadays in my practice I would use it for all of the above, but my initial understanding of stress echo and what I was very interested for was to use it as a first-line test to rule out ischemia in patients who present for the first time, compared to old techniques like exercise ECGs or other more radiation-intensive techniques like nuclear medicine, for example. Mm-hmm. So again, I would like to say that by the end of this, I would try to show to you how a first-line test with stress echo, especially in the contrast era, is useful, cost-effective, and very clinically relevant.
Okay, so we've got some answers here. So actually, 70% of the voting is in favor of all of the above.
So that's excellent.
So
because
that's excellent.
So we have the same group that uses 70% of stress echo. Only a third has access to contrast.
Yes, and 51% use it very, to a very low degree.
Let's see how we can combine this. So, as an interventional cardiologist, I need the answers to some simple questions. Does the patient need an angiogram? What is the ischemic burden of the patient? Is there viability? Do we need to revascularize the patient? Will revascularization improve the prognosis of the patient, or are we just doing it because we can? So let's go back a step. Let's look at this ischemia trial database. So for those of you who are not familiar with this, ischemia trial is a very big trial sponsored by the National Institute of Health in the US. So it's not an industry-driven trial, it's a public domain trial, where we take people who have functional ischemia on a test, and then we randomize them into either revascularization with either a CABG or PCI, or into medical therapy to try to look at outcome. And because it's mainly an American trial, the majority of the population is tested, as you see in the left-hand column overall, with a nuclear scan, and only about a quarter of them is tested with stress echo, although that's slightly higher in the rest of the world compared to the US, mainly driven by people like Professor Senior in Northwick Park Hospital in London. Nuclear is still considered to be the first test when you look for functional ischemia, and the reason for that is historical. The nuclear test is supposed to have higher sensitivity because it looks at perfusion, whereas a stress echo is supposed to be slightly lower sensitivity and has been labeled with this business of being operator dependent with low quality in up to 20% of patients. But of course, we all know that nuclear scans involve radiation. It's a longer procedure. You have to plan, get the isotope. It's a bit more, it's expensive. Whereas a stress echo would be widely available with low radiation at a low cost. And the difference is in this ischemic cascade. When we look at the ischemic cascade, if you look at the top left, you can see that the ischemic acid depression is when most people present to an interventionist in the context of a heart attack. Regional systolic dysfunction is when you get the wall motion changes in stress echo. And further down, as in earlier on, you have the perfusion abnormalities, which was the hallmark in nuclear scan in the past. But nowadays, with MCE echocardiography that Professor Gaibadze demonstrated so eloquently before, you can detect perfusion abnormalities earlier on. So we're bringing the stress echo into the same category of patients as the nuclear scanning. But you can take it at the bedside, and you don't have to use radiation. So when I started looking at stress echo images, if you look at the top left, that would be an image of a stress echo trying to be attempted a few years ago, a decade or more ago, where you could struggle to see where the wall motion is, where the endocardium is. People will play around this for minutes. Experts will turn every dial on the echo machine, will turn the chroma scale up and down, and then it will say, yeah. And that is what made operator dependent. Less experts like me would try to get a better image by doing what's on the top right. So by essentially getting better picture of the endocardium, but for shortening the ventricle. If you look at the apex there, it's round. And the apex is not supposed to be round at rest. Right. But you would fool yourself that, oh, this is a good image, let's work on this. But the bottom is with contrast, and you can see now the nice conical shape of the apex. You can see the endocardium quite clearly. You can see the epicardium quite clearly. So you can see wall motion and thickening, which is the hallmark of contrast echocardiography. And we have some studies.
And do you think, I mean, going back to the image, and do you think the fact that you mentioned that stress echo has lower sensitivity, apart from the fact that it was not looking at perfusion at that stage, this is also a reason where, without contrast...
This is the thing that doesn't have the test as reproducible. You need to have an expert. You need to have it's more operator dependent when you don't have the contrast.
Yes, and also the fact that you're foreshortening the apex, and that's where most of the wall motion abnormalities occur.
That is what the
and you miss coronary disease, but with contrast, you actually don't miss the, you don't foreshorten it.
Much. Exactly.
And you see the wall motion abnormality.
So when we look at studies demonstrating this, so there is a study by Jung published in 2008, where just by giving contrast, and this is people who underwent dobutamine stress echo and had intermediate coronary lesions, and then you compared what these lesions were with myocardial FFR or angiography, the sensitivity and accuracy of the test increased dramatically between the contrast and non-contrast groups. And another study from the US, and this is in a center that does a very high volume of stress echo. So this is not non-experts becoming better. These are experts becoming better. When you give contrast, you increase the number of segments you can see, you increase the number of segments you can see at stress, and you increase your confidence. So imagine as a non-expert operator like me, if you go from 36% to 74% as an expert operator, as a non-expert operator, you start even lower. So your improvement with contrast and your reproducibility with contrast will be even higher. So in our center in Northwick Park, we did a study that would be almost inconceivable a few years ago. We took people, the study is called SUMO. It's not very politically correct, but it stands for stress ultrasonography in the morbidly obese population. So these are all comers. There's no preselection involved. The only inclusion criteria, people had to be morbidly obese, defined as a BMI over 35, and they had to have a clinical indication for stress echo. These are people that 10 years, 15 years ago would not even be referred for a stress echo because nobody would take an image of them. But now with contrast use, which is 96% in this study, we could achieve diagnostic images in 200 out of 209. So forget this 20% thing. It's now less than 2% that you can get diagnostic images. And we can say they're diagnostic images because when you follow these people up, 88% have a positive predictive value for CAD on angiography. And the negative event rate in the negative group is less than 1%. So it compares with every stress echo population in major studies. So if you take a case, probably one of the most extreme cases from this study, this is a 49-year-old lady, risk factors, and the BMI of 56. Not the heaviest person you've seen. 128 kilograms is not the heaviest person in London, or most of the world nowadays, but very high BMI because she was round. So she wouldn't fit in a CMR scanner. She was over the weight limit for our nuclear table, possibly some of the old nuclear tables we have. And she was too tachycardic for a cardiac CT. And without contrast, this is the sort of image you get. You can see how far the apex is from the chest wall just by looking at this, but that's as much as you can tell. You can't tell where the endocardium is. But when you give the contrast, you can all agree that the pictures become diagnostic. You can comment on these pictures. And you can see that there is some apical ischemia, but you can see the endocardium, you can see wall thickening, you can see my endocardial definition. So somebody who would not even be considered for a test a few years ago now can have a stress echo.
So in short, Kostas, you showed the very first slide about low sensitivity, low diagnostic yield, which makes it not a user-friendly technique.
So that's historical.
Now, just by using contrast, not even looking at perfusion, just for wall motion, the sensitivity goes up, and also the diagnostic images go up to about 98%.
So what I'm trying to convince is even people who are not experts in using contrast of myocardial perfusion, by using contrast just for wall motion, you will increase what you can do in your
that's exactly
in your
what the
stress echo
studies have said. Yeah, absolutely.
So if we look at another case, this is not from the SUMO study. This is a bread and butter case from our department in Northwick Park. So somebody who had presented through our chest pain clinic, and you can see the picture on the left is rest, the picture on the right is stress. There is some lateral wall motion abnormality. And the reason I'm showing this case is when this patient went to have an angiogram, and hopefully this will play in there, I'm afraid they play in the wrong order, but if you look at the picture on the left, this is a small circumflex vessel that most interventions you will look at and kind of snigger at. Is that worth doing anything to? I mean, it's too small. Let's give them some medical therapy. But we've got a sufficient burden of ischemia on the stress echo to put a stent into this. And there is the stent here on the right. You can see the stent without the contrast. This is the proper contrast, not echo contrast. This is the nephrotoxic contrast. Yes. And if we repeat the stress echo after the PCI, you can now see this vigorous contraction of the lateral wall. So you're in a small vessel, we determine the ischemic burden, we revascularize the patient, the ischemic burden is going. Hopefully that improves prognosis because we kind of have a link between ischemic burden and prognosis in some studies.
But what it also shows is the fact that the interventionalists, and you did not do the angioplasty,
no, I did not do
by somebody else.
No. I was
looked at the image,
but at the time they were convinced that this is enough to put a stent into this.
So they were so convinced about the ischemia when they saw the image that even if they didn't see a real tight lesion, they opened it up, knowing that it is.
Yes, I mean,
and you've been proven right with the stress echo subsequently.
So we've proven that we can do it, or well, I've shown that we can do it in our center in people who would not have it before, and in people that, and we would revascularize people that wouldn't before. Is it cost effective? Well, this is a study that we did in a randomized prospective fashion, comparing stress echo to the cheapest alternative, which is exercise ECG. And the problem with exercise ECG, if you look at the two left-hand columns and look at the yellow bands, even after an exercise ECG, there is about a third of patients who are in the indeterminate intermediate risk. Whereas if you look at the stress echo columns, the two right-hand columns, about 95% of patients become negative. So we can discharge them without any downstream investigations. And if you take that into account in a, I repeat, randomized prospective study, the average cost for somebody starting in an exercise ECG fashion is much lower than in the people, in an exercise stress echo fashion, is much lower than in somebody who starts with an exercise ECG. But this is only possible because of contrast. If you look at the third from the bottom, sorry, my pointer isn't very good. The echo contrast is used in 173 out of 191 stress echo patients. And nowadays in my practice, I don't think about it. Anybody who has exercise stress echo, we just give them contrast. And I've been, well, we ask for allergies. We haven't had anybody abandoned because of that. If somebody is properly allergic to sulfur-containing media, maybe we'll think about twice. But other than that, everybody has contrast. And even if you take the contrast cost into account, it is still cheaper to do the stress echo than to do the...
So this study actually highlights 2 points, in my opinion. One is the fact that exercise ECG is still considered as class 1 indication for looking at, for establishing myocardial ischemia in patients who can exercise and who doesn't have resting ECG changes, is both in the ESC guideline and in the American Heart Guidelines. The reason is it was found to be more cost-effective than nuclear techniques.
Yes.
Most of the studies were comparison with nuclear techniques, as a result of which it is still there. But today you've shown this study where stress echo is now more
exercise
cost-effective.
ECG and exercise stress echo has exactly the same risk, in my opinion. And the data you get with exercise stress echo is twice as good.
Yes.
You get all the functional data you get in exercise ECG.
And you don't get inconclusive tests.
And you don't get inconclusive tests.
And again, here contrast helped you to achieve this. And then again, it supports the guidelines that has been written recently, where it says you must use contrast in stress echo in all patients, even if you see all the parts of the myocardium, and especially if the patient, when the patient takes a deep breath, the myocardium disappears, you must use it. So you essentially in your practice do that.
So this is my practice now. This is outside our research department.
Yes.
This is now me in real world in my little DG8 or average size DG8. So standard patient, 70-year-old, through a rapid access clinic, diabetic, hypertensive, hyperlipidemic, has a stress echo, and with contrast, and you can see there is a wall motion abnormality on the right in the apex and the apical septum. So I look at this as an intervention. Just bear in mind, I'm the consultant who sees the patient in clinic. I do the stress echo, I look at this, I said, okay, this is going to be an LAD lesion. We're probably going to end with some revascularization of the LAD territory. We take them in the lab. It would be embarrassing if there was no LAD lesion. But there is an LAD lesion, which you can see on the left. But if I go into the right, and I try to freeze it, there is also a lesion. Oh, go back. Sorry for this. If we look at this again, hopefully.
Try to move it. Okay.
Right. So let's see if we can make that play without going to the next slide. Which I'm failing again and again. What I'm trying to illustrate is that the lesion.
Yeah, move the mouse.
Here we go. Thank you. Yeah, if I freeze it there is a lesion actually that starts in the mainstem and extends into the LAD. So the lesion is much more proximal than I would expect based on the wall motion data. And there is a possibility that had I had access to perfusion, maybe we could see a bigger territory of ischemia where we would expect this. In fact, patients like this that are recruited in the ischemia trial go from having a functional test to having a CT. And if the CT angiogram shows mainstem disease, they are put down they are not randomized, they're put down the field for surgical revascularization, which is what happened in my patient. We sent him for a surgical opinion, because when I did FFR on that, it's actually positive all the way up. So I would like just to finish by an MCE example, just to illustrate again a point that obviously Dr. Garbazi illustrated much better, that you get much better wall motion pictures when you do MCE on the left, but you can also do a triggered MCE on the right, where you take the wall motion out of the equation. So you don't bias yourself by looking at wall motion. This is just pictures taken in the same part of the cardiac cycle. On the T wave, you can see the red pointer coming along. And it's a normal MCE, this one, but you can see that you don't look at the thickening, you just look at the perfusion. So you can do it independently of wall motion if you wish, if you feel that you're going to be biased by wall motion. But if you do it in addition to wall motion, then you get additional data. So and you can do both in the same patient. This doesn't take much longer than the...
So essentially what you're saying is, by doing real-time imaging, you look at perfusion and function together, but in order to just concentrate on perfusion, you can do the triggered imaging
And you can do this at rest.
And you see the perfusion abnormalities.
And you can do this at rest to look at viability without having to involve any vasodilatory or chronotropic agents in people who have high risk. So if I go back to my original questions, if I can, does my patient need an angiogram? Well, hopefully, not as a first-line test anymore, but if we demonstrate functional ischemia, then yes. What is the ischemic burden? Well, now it's 3 segments or more. 3 segments or more carry prognostic significance. But if you do perfusion on top of wall motion, you may unmask actually more of an ischemic burden. Is there viability? Well, perfusion there is much more sensitive, and it's actually safer. We've got cases where we did perfusion at rest in patients that had such a high ischemic burden and even a very low dose dobutamine, which would be what the traditional approach would be, made them ischemic, so you would have missed viability. But the perfusion was quite clear. There was perfusion throughout the myocardium, hence the myocardium is viable. So in these patients, does my patient need revascularization? Well, yes, if there's significant ischemic burden, most people would argue that you would revascularize patients. So not on the anatomical data, not as Dr. Gaivaldi showed, not in somebody who has a 60% CT coronary lesion, but someone who has a significant ischemic burden, you will say, well, we probably need to revascularize. Does this improve prognosis? Well, we would all hope so. and hopefully some of the ongoing trials will answer that question in a most robust fashion. So thank you very much.
Thank you.
So now, thank you very much, Kostas, for this presentation from your from the interventionist point of view. But I think it's time now to answer some question raised by the viewers. So let's look at some of the question. So, if a patient has known allergy to eggs, do you inject contrast, example Sonoview?
I have. It hasn't been a problem. But there are alternative contrast media available.
Yeah. But we know that actually the only contraindication for Sonoview is actually Sonoview itself. It's not egg, it's not any other condition. So that's the only contraindication.
So I've worked in centers where people were so afraid of allergy that anybody with any allergy to anything wouldn't have contrast. And I've worked in centers where we were very liberal with contrast, and the allergy reaction rate is the same.
These types of allergy. There's people saying I'm allergic to cardioaspirin or whatever just because they have some stomach ache.
Yeah. But certainly the question about eggs is not a contraindication for Sonoview. Okay, so what modifications can be needed in a diabetic nephropathy patient in terms of giving contrast?
Nothing.
Okay, so this is very important because I think out there when we talk about contrast echo, they think of radio contrast agents or MRI contrast agents, but this is not really the same as that. It's more like an ultrasound enhancing agent. So it has no nephrotoxic effect at all. So it can be safely given in any patient.
I think it would be easier if people think of it more like a bubble study, but even safer than that because you don't have the risk of giving a big bubble.
That's right. That's right.
Yes, you're right.
Okay, so sorry, this we've replied. Okay. Okay, what practical tips are advisable for a good performance from the technical point of view, in particular for perfusion? So, Nicola, what do you...
Well, I think that one of the first lessons to be learned in contrast is that you need to, in contrast imaging, is you need to know how it works, how your machine works, and the typical first thing that you see when people who don't want to ask, they want to ask you how to work with the machine and the contrast, because maybe it's your older colleague or something like that, is that they inject contrast and they do not change anything in the machine, and you see the contrast exploding in the myocardium. And so the first thing to know is that perfusion is like the university of contrast echo. You first may be more comfortable using it for wall motion, which encompasses also perfusion information. But perfusion tends to be a little bit tricky. You need to build a learning curve, but personally, I learned myself with some CD from Dr. Roxy Senior, who was explaining and teaching. So it's nothing that difficult. It's not difficult. And nowadays, when you can use real-time imaging, it's really easy.
Yes. So the bottom line is, for every technique that we use, there has to be some expertise with some training done.
Yeah.
And then use the technique, not just by
start the technique and then learn. Yeah.
Absolutely.
But I think I may be heretic here in saying that if you take somebody who has no aspect of echocardiography to train them to do a transthoracic echo, that jump is much greater than if you take somebody who can do transthoracic echo to teach them how to use contrast.
Right. Yes. It's a small step.
It's a very small step.
Absolutely, absolutely. Right. So, but training is essential, and there's no doubt about that, yes. So more questions coming up. So let's see. Okay, what about adenosine stress echo with contrast without perfusion? In other words, you're not looking at perfusion, just looking at wall motion.
What do you think, Roxy?
Okay, so Nicola, if you're asking me, yes, I mean, if you're just looking at wall motion, then the sensitivity is not great, because the stressor itself is not enough to provoke wall motion abnormality. So you have to look at perfusion. So without perfusion, I don't think it's a good idea to do.
The one thing that you see, as you know, I'm a hard dipyridamole user.
Yes.
I use it in the high, as a high dose of 0.84, 6 minutes. That's my standard protocol. And the one thing that you see that may explain the differences between vasodilators and other types of stressors, such as dobutamine and exercise, is that wall motion tend to come later, much later than perfusion. So
yes.
I'm not even sure that if I were to wait for some minutes more when I see an isolated perfusion defect, I would. But this makes the test safer in any case. So when you use vasodilator, you need long periods of high vasodilation. So this is something that happens at high absolute numbers with adenosine, but for a very short time. So probably not enough to induce wall motion abnormalities consistently.
That's right. That's right. Okay, so going on. Okay, is contrast rest echo better than strain imaging for detecting ischemia? That's an interesting question.
Do you want to answer?
I personally don't have experience in strain imaging, but I know centers in the UK that do prefer strain imaging. So I can't assess both techniques, but I would say that strain imaging is much more operator dependent in my experience of seeing the technique than
I see a difference from my point of view. Is that you see with perfusion and wall motion using contrast, you see the defect and the wall motion, while you need to trust the numbers when you use strain. So it may be useful also, but you need to trust the numbers and not think that this is an artifact. While you have a feedback using contrast, you perfectly realize when something may be an artifact.
Yes.
You don't know when the machine just spits out a number.
Yes, and also with contrast echo, when you're looking at perfusion, and as we know, perfusion is always more sensitive than any
wall deformation,
or wall motion abnormality. So, yes, in that way, perfusion would be better to look at. But you can combine the two together in the same test.
The actual question that, as you know, we're interested in is if you have perfusion at rest in somebody who presents with chest pain before you get enzyme rise. Is that diagnostic? Would you be able to send somebody home when they have normal perfusion at rest before you wait for your troponin in 3 or 6 or 12 hours? That's
right. So a study has been done, as you know, has been published in 1,000 patients, where it was clearly better than you can actually discharge patients with normal wall motion and normal perfusion. So I think we actually now approaching the end of the webinar. I would like to close this webinar by highlighting the key take-home messages from this webinar: that contrast stress echo improves wall motion assessment in our daily clinical practice. It gives interpreters confidence in wall motion assessment. It is a cost-effective technique compared to exercise ECG. Perfusion information is very feasible during stress echo. It provides both incremental diagnostic and prognostic information beyond wall motion. Both wall motion and perfusion help guide which patient may benefit from coronary intervention. And low MI contrast specific imaging techniques should be used for optimum assessment of wall motion and perfusion during stress echo. We will now close the webinar. Thank you, Nicola. Thank you, Costas, for this very informative presentation. And finally, thanks to Bracco, Milan, Italy, who supported this webinar with an educational grant. We hope you enjoyed this time with us. You'll be able to view again this webinar offline in a few days on the ESC website. Thank you.